appendicitis. In other words, it's been going on for a week or more. On the other hand, if he sees mostly monocytes and macrophages, his description will be chronic appendicitis. That this is a process that's been going on for at least a couple of weeks. So he'll be able to tell duration based upon the composition of the white blood cells. Does that make sense to everyone?
If it's chronic, does it mean that they have underlying issues?
No,
Or
it
not
means that they didn't
necessarily?
come in right away. It means that they've been having some pain that they probably thought was a little bit of GI upset or maybe something they ate. They ignored it. It kind of eased up. It flared up a couple days later, and they thought, oh, it's coming back again. But it didn't present in such a way that it prompted them to go to the hospital right away. Everybody's got different pain tolerance also. You know? I may have a headache, and I'll take a couple of Tylenol, and I'll avoid going to the hospital. JJ may have a headache, and she's in right away. Everybody's different.
That's true, I go to the hospital.
Okay. We're not judging. Okay, this is a safe environment. Okay? This is a safe environment. Notice that I said a red blood cell is 7.5 microns. 18. So it could be 2-3 times the size of a red blood cell. All right, this is a monocyte. Okay, it's so big that, look, it's compressing some of the surrounding red blood cells. And that's why you don't want to sit next to it on a plane. Okay? It's too big. It's taking up more space than it should be allowed. Now, notice that the nucleus tends to be folded. I used to say that, and this is the description in textbooks, that the nucleus of a monocyte tends to be horseshoe-shaped or kidney-shaped, and oftentimes that's true. But I like to use the term folded because sometimes it's not horseshoe-shaped or kidney-shaped. Sometimes it'll look like this even, the nucleus. So it doesn't always need to be horseshoe-shaped or kidney-shaped. The type that it's most confused with is the lymphocyte. In addition to the size, though, it's much bigger, the cell is bigger than the lymphocyte, the nucleus is not as deeply, darkly stained. In fact, it's more variegated, or what people call lacy, meaning that there are areas of dark staining right next to lighter staining regions. So that variegation helps to differentiate it from a lymphocyte. But like the lymphocyte, there are no granules in the cytoplasm. This is a little bit uncommon where you see these vacuoles. If you see vacuoles, it helps to identify it as a monocyte, but most monocytes do not demonstrate those vacuoles. Those vacuoles are little membrane-lined vesicles that house digestive enzymes. Okay? Most of the time, you're not going to see those.
So they use the storage?
Yeah, they use to store enzymes so that when they ingest stuff, the enzymes can break them down.
Why is it folded?
Why is the nucleus folded? I don't know. It just is, you know, I don't know. But that's simply a characteristic of monocytes. You know, it's like, why does the neutrophil have a nucleus that's segmented? I don't know. But we can use it to identify. Okay, now eosinophils. Now, when you look at smears, and I'm not sure, we're probably not going to have time to do this today, but when you look at smears of blood, you can have an easy time finding neutrophils and lymphocytes, and even to some extent monocytes. But when it comes to finding eosinophils and basophils, you'll have a little bit more difficulty, simply because they're not as abundant. Eosinophils only account for 2 to 4% of your circulating white blood cells. And here's what you need to know. There are primary defenses against 2 things: parasitic worms and allergens. You know, these are usually proteins in the environment to which we're hypersensitive.
So if you need like allergy shots, do they inject those for?
No, you can't inject. No, allergy shots are when you get the pathophys, we'll talk about that.
Okay.
It's just, we would have to spend 15, 20 minutes talking about that. Not That's a good question. But what you do with allergen shots is you inject little pieces of allergens so that your body becomes, in a sense, acclimated to them.
Alright.
And you gradually build up exposure.
Oh,
It
yeah,
works.
because you had that.
It works.
Yeah.
I know better.
That's good.
So that your body now feels more comfortable with them.
So do people feel kind of icky when they first get the allergy shot?
Yeah. It feels like you have a full-blown cold.
Yeah, that makes sense.
Yeah. So, we don't see many parasitic infections in the United States. We only see, like worms, for the most part, in people who have come over from South America or some other part of the world, usually a third world country.
Isn't there like one from Costa Rica where it's like they inject in your skin and you have to pull them out?
Yes!
Those are so.
There's all kinds of crazy worms. I think.
And it gets stuck in your body?
Yeah. Yeah.
It's like a mosquito. It comes over and it like injects little eggs and then like they live in your skin and like you have to pull them out. You know.
What is the common type of parasite we do see here in the United States, and it occurs in pediatrics?
Tapeworm?
Not tapeworm.
Ringworm.
Well, ringworms is more of a fungus, not a parasite. But pinworms,
Oh yeah.
What is that?
you see little toddlers that are constantly scratching around their anus. Because what happens is the adult form lives in the GI tract, and at night it comes down to the anal region and excretes little eggs into the perianal region, and then it moves back up. And so the eggs trigger a mild inflammatory response, so the kid scratches. They're constantly scratching their perianal region.
So what do they do about that? Like,
Well, what you have to do is make the diagnosis and treat it with a type of antibiotic. And the way you make the diagnosis is interesting. It's called the Scotch tape test.
Oh yeah.
You take some Scotch tape and you put it over their anus, okay? And then you take the Scotch tape and you put it on a slide. It just sticks. And you look at it under a microscope and you see all of these pinworm eggs, well, you know, and they look like little footballs.
no.
And then you make the diagnosis.
Congratulations. You have successfully covered this class to two things I do not want to deal with as a nurse.
What's that? What two things?
STDs and parasites.
There you go. There you go.
You're working in ER, you don't know what you're doing.
Yeah.
You're gonna come up against everything, all comers.
I mean, I'll
Okay.
deal with it.
Now, let's suppose you have an allergic reaction. Most allergic reactions are mediated by antibodies, a specific class of antibodies called IgE. Okay. The first time you're exposed to the allergen, you don't have a clinical reaction. Your body just produces a lot of IgE. Okay? And this IgE antibody then tethers itself to mast cells within tissue. So here's a mast cell. Remember that? You see it's lots of granules. And then the IgE looks like this. The arms of the molecule are what bind the allergen here. So the IgE that's produced in response to exposure to the allergen tethers itself to mast cells. Then, the next time you get exposed to the allergen binds to the IgE, which then triggers degranulation of the mast cell, release of these granules. And remember, one of the components of these granules is histamine. And so histamine is going to bring about the manifestations of that allergic reaction. Okay. Whether it be, let's say, these are mast cells in the nasal mucosa, and you've been exposed to ragweed. Well, when histamine's released, it can cause itching. It can cause your nasal mucosa to get swollen, for your nose to begin running, sneezing. All of those allergic manifestations. Now, what the eosinophils do in an allergic reaction is they come along and do two things. Number one, they can phagocytose the antibody-allergen complex. And secondly, they can release histaminases. These are simply chemicals that break down histamine to help control that allergic response. Okay. So in the mucosa of someone who's got allergic rhinitis, hay fever, you know, if you were to take a smear of that nasal mucus, you'd see lots of the eosinophils. Okay? And that would tell you it's an allergic response. I'll give you an example. One time I looked like a genius. This is fun. I had a lady bring a little girl because she had what she thought was a severe cold that wasn't going away. Her nose was running, she couldn't sleep, she was sneezing. She had been to 2 pediatricians, had been through 2 courses of antibiotics, wasn't responding. Okay? So it's fun. I had a little lab. I developed a lab that was actually used by lots of physicians in the uptown area. But I had access to it because it was in my office. And so I said, okay, I looked at her nose with a little pen light and then with a little nasal speculum, and you could tell that her nose was really inflamed and runny, okay? And so I took a little swab and took a smear from the nasal mucosa, and I put it on a slide, and I stained it. And all I could see was just a sea of these eosinophils. So I went back to the mother, and I said, you can stop all those antibiotics. This is actually an allergic reaction, okay? And so we gave her some steroids and antihistamines, and within a week she was cured. And I like the lady thought I was a genius. Okay, let's just doing anything. You know, when I saw the eosinophils, I said, oh wait. You know, if I'd have seen neutrophils, I would say, okay, this is infectious, it's not responding. But it was just.
So did you give her shots to help it, or was it like?
In fact, yeah. I gave her a little injection of something called Celestone, which is a,
Oh, I get that all the time.
yeah, which is just a steroid.
Yeah, that helps.
Okay,
steroids.
and then I gave her some nasal antihistamine. Yeah. All right. And eosinophils, eosin refers to red staining. They love this red staining dye, okay? So it's a granulocyte, so you see all these red granules. Now, typically, the nucleus is segmented, but this is different than usual. This shows 3 segments. Most eosinophils are bilobed. They look like a telephone receiver, okay, with just 2 segments. The granules are wide enough that you can see the nucleus well. Okay, so usually it's a bilobe, or this is trilobe, and you see red granules. The least abundant, the type of white blood cell you'll have the most difficulty in finding, is the basophil. Okay, basophils only make up to 1% of the circulating white blood cells. Okay, they are related to mast cells, but instead of being located within tissue, they circulate. So these are cells that are chock full of granules, many of which contain either histamine or heparin. And like mast cells, which I just demonstrated, they can be involved in allergic reactions. But if they degranulate, the histamine and the heparin and the other mediators that are released get released not into tissue, but into the bloodstream. And so they can be involved in severe systemic allergic reactions, like anaphylactic reactions. If they degranulate, that histamine is released throughout the body and causes blood vessels to dilate, which can drop blood pressure. Okay? So, just like IgE can bind to mast cells within tissues, IgE can bind to basophils that circulate. And if that IgE brings about degranulation of those circulating basophils, you can experience a severe allergic reaction, or what you call an anaphylactic reaction. Okay. Histamine causes vasodilation and increased vascular permeability. It makes blood vessels leaky. That's why your nose gets congested when histamine's released. Okay? But because the vessel is more permeable, it allows access to phagocytes, white blood cells, which can come in and help to remove the allergens. This is what basophils look like. Basophils, this means basic loving. It's actually, bases, this is the type of stain to which it binds, tend to be blue. And so the granules, which attract this type of stain, tend to be dark blue or sometimes purplish looking. But because they're dark, they obscure the nucleus. But the nucleus would be like the nucleus of an eosinophil, typically bilobed, like a telephone receiver. It's just that the granules are so dark that they obscure the nucleus.
Do the red blood cells in this have poikilocytosis?
No, we don't. That's only a term that's used for red blood cells.
I know, but the red
Oh,
blood
and this
cells
one
that you
here.
see, like they're not.
You see a little bit of poikilocytosis here. Okay, for instance, that cell is kind of oval shaped, isn't it? Okay.
And then, like, you
and
get,
then
like,
look here, you have a little bit of
spiky
difference in a little bit of anisocytosis too. That cell's a little bit misshapen. So yeah, and this one's a little bit oval shaped. So you do see a little bit of poikilocytosis here. All right, so let's look here at white blood cells. What type is this?
Neutrophil.
Bill? Look here, red granules, bilobe nucleus.
eosinophils.
In this one here, there are granules, but we can't really make out the nucleus well. Here we just have a bunch of what? These are obviously lymphocytes. This one's a little bit tricky. It's a lymphocyte, but I could see if someone confused it for a monocyte because it looks kidney shaped. But the key here is that it's solid, dark, and homogeneous. So this is kind of an atypical lymphocyte.
And the lymphocyte is the one that has like a little bit of a cytokine?
Just a little bit of, look at that, just a thin rim typically.
Okay.
These would be monocytes where if you look at the nucleus, it's more variegated. There is alternation of light and dark regions. It tends to be folded. It can be kidney shaped, it can be horseshoe shaped, or simply folded. It's a big cell, no granules in the cytoplasm. Look at this, it's eating something. Now, I think this is last slide, yeah. Okay, the term leukopenia, P-E-N-I-A, means a deficiency of. So in this case, a